I would like now to talk about hypofractionation in cervical cancer, and it's going to be even harder probably than converting the world in breast cancer. So again, I wanted to talk about ways to adapt what we do, but as an interplay also to work on.
Sorry to interrupt.
Okay.
Can I please have you stand by?
Oh, I'm sorry. I thought this was work. It's not working.
Recording for later.
Oh, I'm sorry. So this talk is to look at adapting what we do, but also I want to adapt backwards about how work done outside the United States can positively influence what we do and mimic the breast cancer world, because I think the world of breast cancer radiation in the United States improved a lot, but it was people were very resistant to doing this. This is kind of exciting. This is some work that my institution has done in Africa, on the other side of Africa, in Senegal, in Dakar. And this is on the right side, John Eink and Dr. Zhang. Isn't this Dr. Zhang, John, from Senegal, doing, and there's Kate in between, snuck in the middle, doing the first brachytherapy case, I think, that they had in the history of the country. This was a very exciting day. So the current standard for cervical cancer has been the same for many years, and it was done mainly by trial and error, and then later refined by prospective studies. This is the evolution back in 1903, was actually the first brachytherapy insertion that I could find in the literature. And this is an example from around World War I. On the right side of a field that many of us, when I trained in the 1980s, these are the fields I would use to do the parametral boost. It's very similar to 1917. It's kind of a little embarrassing. It hasn't changed that much. But the treatment has evolved, and probably one of the biggest in my career in cervical cancer, the biggest change was the addition of chemotherapy. And as we can see here, in the late 1990s, in the United States and in Canada, there were multiple randomized trials that showed a benefit in terms of, I thought the little thing would work, showed a nice benefit in cure rates for women undergoing, oh, it's over there, thank you. I was looking for the little pointer. It doesn't work. They had an earlier talk then. I was on the other computer. There's always a different. So you see a nice benefit. This was the benefit that Kate was talking about was lost if we don't do brachytherapy. You get a benefit to adding the chemo, but then if we don't do our job properly, the benefit gets wiped away. So an important question is, are these standard approaches in the US and Europe applicable? And as Kate pointed out, it's a little embarrassing to say standard when we're only at 60% of the standard level, which is very sobering, because we all like to think that we're doing something well, but we're not doing it well in the United States for many I think a lot of bad reasons. There's some logical reasons, but there's some bad reasons. But let's say what the quote standard approach is, that going to be very applicable outside and in the developing world? And I personally think the answer is no. I think it has to be very different. There's major differences, as we all have pointed out. Many centers in the US and Europe, lots of equipment. Strangely enough, low and moderate patient volumes for cervical cancer. It's kind of an odd thing. We have all this supply of stuff. We don't have that many patients compared to, for example, here for it. Lots of personnel, patients don't have to travel far, and most are insured. So that's a really easy thing to do really well. We shouldn't be at 60% of well, but very different in the developing world. And so I think the solution is to adapt what we do to the needs and challenges for the developing world. This is a picture from Senegal, the waiting room, and there's, this is no surprise to all of you, there's one man and all women in the waiting room, because this was such a cervical cancer their use of their cobalt was almost exclusively women with cervical cancer when we visited. It was sobering to the rest of us, where in the United States it's prostate and lots of other things. So the question, how should we adapt? And what should we do? I think a really interesting thing, this was published as a joint experience between our institution and our colleagues in Senegal, looking at an innovative way to do the brachytherapy planning. And this was in the Red Journal about 3 years ago, I think, John? Is that about right? And so this was using isodose overlays, and you can see the overlay that we made on the left side that are used in conjunction with orthogonal films taken at the institution. So they took orthogonal films, we supplied the overlays for the brachytherapy, and there wasn't a need to do computerized treatment planning. It was a very efficient and easy way to do this. And this was, they would evaluate the 90% and the 70% isodose lines, and it would show the relationship to the bladder and the rectal points. And repacking was performed if the criteria was not met. So this was, we were hoping, a straightforward, non-computerized method of doing this if we would prepare these overlays and they could use them. But probably the most important aspect to adapt is not only the use of the physicists and the computerized systems, but also time. Shorter treatments need to be done. They increase the ability to treat more patients on the same amount of equipment. It's easier for the patients who travel long distance, and it decreases the overall cost. If a patient and their family are paying per fraction, it's going to be a better way to do it. Unfortunately for cervix, in the United States and Europe, all the treatments are really long. And so there's very limited data on short course treatments outside of palliation for cervix. That's not true in other diseases. In hypofractionation, which we're going to hear from the next speaker, is actually being adopted in lots of different types of diseases. But in cervix, it's not. For me, the tricky thing in cervix cancer for hypofractionation is you have to shorten the treatment to the pelvis and add brachytherapy. That's not usually what we talk about when we talk about hypofractionation approaches in prostate and breast cancer and everything else. We don't have that added complication issue of adding brachytherapy on top of a hypofractionated course. So it's kind of a really tricky, interesting, complicated issue altogether, but I think it shouldn't be used as a stumbling block for not talking about combining hypofractionation and hypofractionated brachy as well. You don't have to do the brachytherapy with the 4, 5, 6 fractions. We could talk about using 2 or 3. So as I mentioned, it's really in breast cancer, the so-called Canadian, also British fractionation. Can't tell you how many American radiation therapists were ready to die on the beach and fight against this and never do this. Their careers, they would say, if you give more than 200 centigrade a day to the breast, it's going to fall off. It's going to turn into a rock. It's going to be horrible. I was trained that way. So I have to admit, I had a lot of those prejudices too. If you gave, a 212 little point in the breast, it would be this evil business. Now, routinely in the United States, people are being treated with hypofractionation, with chemo, with all these things. It's absolutely exciting. Rectal cancer is another one. Rectal cancer, you can shorten the Swedish. Again, these are all the non-American countries that are doing the hypofractionation, are doing this. 5 days versus the American 4 to 5 weeks. It's doable. It's fine. The surgeries are not complicated by this. Again, no, not the combination of the hypofractionation and the brachy, but I think still hypofractionation in the pelvis is a reasonable and exciting direction to go in. SBRT is an exciting area to go in, and I think there was a question about could this be as a replacement for the brachytherapy. And I think for the really little tumors, yes. For a 2B, a 3B cervical cancer, no. And I think most of the tumors we're seeing, we see because of the economics of the Mexican population, and also in Africa, you see the more advanced diseases. They're not going to be the little tiny tumors that are amenable to SBRT. But I think SBRT is a reasonable and possible approach, I'm sorry, Kate, for the really tiny tumor. I think that there shouldn't be a reason. It works in lung cancer, it's working in liver cancer, so it could be. But the typical cervix cancer patient, no, I don't think it's the right way to go. So there's really been absolutely minimal, I might be corrected with the next speaker, of looking at hypofractionation in the cervix situation. I don't see much of this. I don't hear much about this. And this is frustrating because this is a common situation many places in the world. So here's the approach for cervix. We give the chemotherapy, which is the lines at the bottom, long course of external beam, and the brachytherapy. Sometimes we overlap the two, but this is let's say this is a typical course. What I think is really we got to move to something like this. We got to move to the hypofractionated external beam, hypofractionated brachytherapy. But you see, we're giving up a few things. We're giving up the cycles of the chemotherapy. That could hurt. But maybe the hypofractionation plus the chemo makes up for that decrement. I don't know, but that could be. And the brachytherapy is shorter too. Could that be okay, or could that be not okay in the setting of hypofractionating the pelvis? These questions are the really burning questions. They need to be answered, but I think it's an exciting area to look at because it could modify the standard of care approach outside the United States and inside the United States over time, because many of our patients are the poorest Americans who do have to travel, who don't have the means to. So there's some interesting similarities, as Kate pointed out, between cervical cancer inside the United States and outside that we can learn from and improve the care of our patients. And this is a busy slide, but what it basically shows, I don't have my pointer. These are from John Eink's paper with Senegal. Oh, you found one.
Yeah.
Mira is always able to fix things. Oh. Did I do this? So what it's basically showing is this is a summary. Thank you. This is a summary of a slide that Dr. Eink put together of all the hypofractionated brachytherapy regimens. And you can see there are a number of ones that are 2 and 3 fractions. I'm very excited about the 2-fraction brachytherapy approaches, many of them from India. And I think this is a really exciting look at, can brachytherapy be hypofractionated as well? We are giving higher doses per fraction, so there is a worry of doing that. But I think that worry has to be put into a context of also need. So treatment, as I said, involves both. So there are concerns. There's always going to be concerns. But there's a lot of, I think the positive is going to outweigh the concerns. We're going to need to do this. And I think we really need to study this. And this is something we can all study together because it's going to impact all of our patients. A randomized trial is never going to happen. This is not going to be tested in a randomized trial. I think a consortium between United States, Europe, Africa could really look at this and could really answer this question. And I envision treating women in a systematic way and assessing their outcomes. And I think the collaboration that we've been doing in Dakar, I think, is something that can be really expanded and could look at this. And it could allow us to look at doing brachytherapy, doing external beam all together in a very novel way. And I think I think it's only really going to be together if we're going to do this well. So I would encourage these partnerships, and I think a number of partnerships are forming between the different regions in the world for this type of thing. But I don't think the mistake would be just doing what we're doing now. Because as you can see from breast cancer, what I'm doing today is not what I learned how to do. So hopefully we're just not going to just take the standards and put them somewhere else and then not evolve. I think we should all work together and become a much better world. So I think there's an added benefit because the positivity that will happen backward to us. And I think that's really important because I don't think the United States is going to make those next leaps unless this type of research is looked at. We're going to stay the same. And so, as I think Kate pointed out, here in our world in California, in the United States, less than 50%, was it, I thought it was 61, I'm sorry.
COC says 60, the GOT said less than.
So less than 50% of the Californian women with cervical cancer get optimal treatment. I mean, it's sobering to see this. But maybe shorter courses are going to help that, because if a patient lives far away and they don't have the means to travel in California, a shorter treatment might make treatment possible where we don't have it today. So this wasn't the one. I also had a slide, I'm sorry, I had an updated one that I must have not given you, of the outcome from our patients treated in Senegal. And this was just presented at the American Brachytherapy Society. It was very exciting. It was using the overlays, but not using hypofractionation. And it showed that it was feasible and it had a very good outcome with a low rate of toxicity. And I think, John, you want to say a word about that?
Yeah, I mean, as I'm sure I'm preaching to the choir here, getting follow-up on patients who have come from, 10, 12 hours away after receiving radiotherapy is quite difficult. So I think this was a treatment of our first 64 patients of whom we had follow-up on 46 with really excellent local control of about 70%. And there were very few cases of radiation bronchitis, despite the fact that the clinic in Senegal uses a hypofractionated regimen on many of their patients.
Okay.
300 times 10 APPA and then 300 times 5 using laterals. So a fairly hypofractionated.
Yeah. And I think there was one problem with the American publication literature. They looked on the follow-up rate, meaning was a reason to exclude the paper from publication. And I think, it got forced down, I think
We're now on journal number 5 in terms of
yeah,
trying
it's
to
just,
get this thing published. But,
and it's so frustrating. It's like it could be a change in the paradigm of the treatment of cervical cancer in the world, and they get mad if we don't have the same follow-up rates as we would if the patients just lived in San Diego, California. It's just maddening.